Our panelists, and I'll invite them to come as soon as I've introduced Dr. Bell. He was appointed Deputy Minister not so long ago in June of 2014. Might feel a little longer than that, Bob, I'm not sure. Prior to this, he served as President and CEO of the University Health Network for 9 years. He was trained at McGill and U of T. He's actually originally trained as a GP and eventually as a surgical oncologist focusing on soft tissue cancers. So Bob has been a tremendous contributor to the health sciences community in Toronto and in Canada at large. He's a spectacularly competent, hardworking, hard-navigating guy who gets the job done, and we're absolutely thrilled that he's here today to moderate this panel for us. Bob, thank you.
Thanks so much, Terry. And as Michael said, we've all worked for Terry from time to time in our careers, so it's great to come and participate in this CEO Forum with Extra, which I've had the opportunity to participate with in the past, and certainly some of our teams from University Health Network have thoroughly enjoyed their time working with Extra and indeed have made real impact in the way that we provided care, and particularly at Princess Margaret Hospital. I think one of our best teams with Extra participated from our cancer program. So I'm just going to briefly add my comments to the topic of the day, that is organizational innovation in palliative care, speak to you briefly about the Ontario experience. I'm going to introduce my 5, I believe, panelists. Thank you, Terry. And they are going to speak to you also briefly. They are then going to lead you in breakout sessions. We'll have the directions that you go. You're going to come back after exactly 25 minutes. We're going to have a report back from your teams on questions that we provide you with. And this is the most innovative use of about an hour and a quarter in the history of a medical meeting that I've ever seen. We're going to get a lot out of you over the next little while. So first of all, let me tell you about the Ontario experience in palliative care. And I'm particularly delighted because the focus on palliative care began with a conference that we organized at the Cancer Quality Council of Ontario. Holding CCO, Michael was, I believe, just started as president at the time as CEO. And we said, Michael, why don't we have better organization of palliative care services? Michael, to his credit, said, this is not a cancer problem. If you're going to organize palliative care in this province, you need to bring our regional health authority leaders to the table to help us understand not only how cancer organizes, manages palliative care, but also how the broader healthcare system is organized around palliative care. And that was a striking piece of work on Michael's part, because it has led to a broader definition, of course, as you recognize, I'm sure, through your day-to-day, of patients who need palliative care. Recognizing that question, the uncertainty question that clinicians have to answer, recognizing the transition from cure to care. And that transition is as true for cardiac patients as it is for cancer patients, and it's recognized simply by the clinical question of, would you be surprised if this patient were to pass away in the next year or so? And if the answer to that question is no, I wouldn't be surprised, then you're focused on a patient whose needs are perhaps best served by starting to consider a palliative care option for that patient. And that transition is not black and white, it's gray. We all know that you start to think about care options as opposed to cure options, sometimes at the point of diagnosis. I was fortunate to treat patients with, as Terry mentioned, musculoskeletal oncology, and a patient presenting in my clinic with an osteosarcoma of the femur who had metastatic disease already evident in their lungs. There was certainly a cure option available for that patient, but in that gray definition of the boundary between cure and care, it was essential that we start talking about options regarding palliation, the symptom comfort, control, and crucially, education for the patient as they started on their course of treatment. And I think that's something that the Ontario Palliative Care Network approach has tried to emphasize. It's based on facilities, it's based on the expansion of hospice facilities through the province, it's based on increasing the numbers of clinicians focused on palliative care, but probably the most critical issue is identification of patients at an early stage who could benefit from palliative care services, home care services, house call services, and crucially, education services. Because in my experience, and I'm sure in your experience, the most important issue preparing a patient for a good death is preparing the patient to understand the processes of care that will be there, talking about symptom management, getting them to open up about the things that they and their families are concerned about, are afraid of, and providing them with the information as to how our system will respond to those needs. In my experience, that conversation with families present, the whole caregivers involved, family members, friends, the extended community of care providers, that's one of the most valuable things that this approach to palliative care provides. So the systematic approach that's taking place in the Ontario Palliative Care Network has hard metrics. It has metrics related to patient visits to the emergency department within 2 weeks of death or 2 months of death. It has metrics related to hospitalization for patients. It has metrics related to the proportion of patients who approach death at home or in hospice. But most importantly, it measures the patient experience as well. And the patient experience, the understanding of what services are available, how those services are accessible, the crucial importance of communication with the care team as palliative care progresses. These are things that the Palliative Care Network has focused on. And I think it's fair to say that the most important metric that we count on is that experiential metric, the patient experience in being provided palliative care, as well as, importantly, the staff experience as well. I think it's recognized that palliative care can be one of the most rewarding careers that we can pursue in clinical medicine. At the same time, the ability to train staff, especially in the mindfulness and the reflective elements of practice, the ability to grieve, the appropriate way to communicate about patient experiences. This is one of the other things the Ontario Palliative Care Network has really focused on. So Michael and I would be delighted to provide you with any other information about the OPCN that would be appropriate. We're trying to build this into our new Patients First model of a regional health authority integration of services in Ontario. The concept that every Ontarian needs to belong to a care community with comprehensive primary care and services organized on a geographic basis for the services that we receive in the community, which represent probably about 98% of the services that Canadians receive in a publicly funded health system. Not hospital services, care communities focused on primary care, mental health and addictions, home and community care, and of course, palliative care in communities. So this focus on community service, organization of services, including palliative care in the community, is something that we're really working hard at. You know, it's a multi-year cultural change process, but a focus on palliative care in the next year of our transformation, Patients First transformation. My goodness, isn't that a tired word, transformation? We use it so often. But this truly is something that we feel will be transformative of care in Ontario. We're going to be focused as one of our first challenges to our care communities to ensure that all patients have access to this community-based palliative care network. And we think that's a very good way not only to provide better palliative care, but also to focus on the integration of services within community care communities. So thank you for the opportunity, Terry, to come and chat today. I'm looking forward to more learning from you than teaching you anything. And I'm now going to introduce my fellow panelists to come to the podium, if you would. Would you like to come up all at once, or would you like to come up one at a time? How about all at once? All at once. I'm getting the signal from the back of the room. It's all at once. So, Trish Cochrane, Becky Palmer, Dores Barwick, Alicia Babiak, and I missed somebody here. Vincent, please. Vincent Dumais. If you would please all come to the podium, and I'll introduce you as you come up here. We'll introduce you as we introduce your topics. So our first speaker is going to be Trish Cochrane. And is that right, Trish? Is that what you're expecting?
I am now.
You are ready? So, Trish is Vice President, Integrated Health Services Program, Primary Health Care and Population Health. She began her career in public health, practicing as a community nutritionist. She has her recent role, Vice President, Community Health and Continuing Care with Annapolis Valley Health. She's recognized as a leader committed to creation of strong interprofessional teams, a graduate of Acadia University, University of Toronto and Dalhousie, certified health executive with the CCHL. So, Trish, over to you, please.
Thank you. Are we on? Yes? So thank you for the introduction. I'm delighted to be here today and yesterday. I can't help but recognize the teams from Nova Scotia that are here as well. We're very proud of the work we're doing in Nova Scotia and humbled to hear what others are doing. So thank you for including us. The question around what is required around system transformation to accelerate, improve access to palliative care. So when I started to think about it and then reflect on what we've been talking about the last 2 days, some of the foundational pieces for us are the national strategy, the way forward. I think it's really galvanized support for an integrated approach to primary health care, and now the federal government's commitment around, we see an indication for a commitment, and our ability to influence what that looks like over time, I think is going to be significant nationally. On a Nova Scotia front, we did develop a strategy in Nova Scotia. It was guided by the way forward, and also I think our context in Nova Scotia, with the pillars being accountability, and you've talked about indicators, and I think we have to measure our progress over time. Integrated service delivery, that's easy to say, it's not easy to do. So, but that is part of our framework in Nova Scotia, a focus on family and caregivers, and capacity building and practice change. So in our province a couple of years ago, we were once again reorganized as a health system. And we are now one Nova Scotia Health Authority, which you've described Ontario. We have the majority of services integrated as you've spoken of, with our IWK Children's Hospital being a separate organization. So we've been in the midst of, we're into year 3 of an organizing one system of the health system for Nova Scotia, honoring the previous organizations as honoring the people and the practices and the perspectives they brought, but reorganizing with a vision of balancing the traditional healthcare system and a renewed or an enhanced focus on community care and on the health of our Nova Scotian population as a whole. So while we've been in the midst of that, and as many of you have been involved in these reorganizations, it's not small. It's not small for our staff, for our leaders, for our physicians, and for our communities. But as we've been doing that work, and the transformation of what a new enhanced system needs to look like, we have pulled palliative care into that. And one of our key focuses in Nova Scotia is creating a renewed primary health care system. And we're not different than any other province or probably the rest of the world, if not North America, in that way. But our government has just been re-elected with a platform that sees primary health care as a foundation, and it's significant. So we've been trying to enable and advocate for that as a healthcare system over the last year or two. And significant that 3 political parties have all put themselves behind an election platform around health that puts primary health care high on the agenda. So our palliative care work in Nova Scotia, while it has many facets, and I'm going to describe a few of them, is grounded in the connection between palliative care based in a primary health care system as the foundation. And our project that our extra team has completed is delivering on that, doing the operational end of it. What are the, so some of the activities we've been involved in, just quickly, because I think the initial, the one-on-one initiatives, the large ones and the small ones, they are very significant as we build transformational progress. You've heard about the paramedicine initiative that we collaborated with PEI and also Alberta in our province, the extra project that has been featured. We've developed a competency document across, and I think there's national interest in what does that competency document look like for all providers. What's their scope, what's their work, how we work with our universities to start training palliative care within that competency document. Lots of research partnerships, expected death at home, as a part of the paramedicine program, a bit separate, but trying to have no police coming with sirens going, so a protocol in place. Advanced care planning, as many of you are working on, we don't see it just as related to palliative care. It's advanced care planning for all of us. The role of patient advisors, indicator development, a clinical palliative care network at the provincial and the zone, what we're calling zone level, around quality improvement and measurement and so on. So a number of initiatives, and the team that is here today have all been instrumental in that work. What are the enablers for this transformation to continue? We can't underscore the value of organizations like CFHI, the Canadian Partnership on Cancer, that ability to come together, the grants that are available. Some of our organizations, I would say lower tax bases, don't tend to have the money to do some of the innovative development. So that's examples of what we're up to, as we're also trying to create a new effective organization in the province. What will it take in the future?
And Trish, I'm going to be absolutely rude and ask you if you'll come to conclusion, if you wouldn't mind.
For sure. I think collaboration versus competition will be extremely important across the country. Bringing the public in, a public health approach. We heard the complexity science this morning. We have to look at it that way. Appealing to those who want to work with us and not expecting we're going to transform over time. Be ready with a vision, and when the opportunity presents itself, be ready to act, would be some of the things into the future.
Thank you, Trish. Next, we have the opportunity to hear from Monsieur Vincent Dumais, who holds a finance degree, a Master of Science degree from Haute Études Commerciales in Montreal. And really importantly, has lived experience from chronic disease and has been active in the promotion of the patient partner concept at the Université de Montréal. And I think probably one of the best examples of patient engagement in the strategy and development of clinical programs. In October 2010, he created the Patient Partner Program at the Faculty of Medicine and now co-manages a larger organization with Dr. Paul Lebel, Collaboration and Partnership Unit at the university. He's worked on various projects related to patient engagement for a variety of organizations, including CIHR and INES, sits on several governance committees and develops the strategy for these institutions. Thank you, Vincent, for being here today. We look forward to your remarks.
So I'm going to speak in French, so I invite you to... Alors merci beaucoup pour cette invitation, ça me fait très plaisir d'être ici à ce panel en tant que patient. Donc je suis un vieux patient, je suis un hémophile sévère. Donc je suis dans les soins depuis 46 ans et j'ai été contaminé dans les années 80 par le VIH et l'hépatite C. Donc j'ai le concept, la vie avec la mort fait partie de mon processus depuis une trentaine d'années maintenant. Peut-être le premier message que j'ai beaucoup écouté ce matin, j'ai vu tous ces projets magnifiques. J'avoue que j'étais très impressionné par le travail. Je suis membre du CA, du board de CFHI, mais j'avoue qu'aujourd'hui, j'ai vu le détail de tous les projets qui étaient là et j'avoue que j'ai été extrêmement impressionné par tout ce qui a été présenté et la diversité des initiatives présentées. Alors déjà, félicitations à toutes les équipes. Ça m'a marqué parce que vous savez, moi, j'étais un activiste SIDA dans les années 80 à Montréal. Et bien entendu, une de nos activités n'était pas seulement de se plaindre contre les gouvernements, mais c'était aussi d'accompagner nos amis à travers la mort. Hein. Donc les années 80, on enterrait une personne par semaine dans le village gay à Montréal ou dans certains quartiers de Montréal. Et bien entendu, ça se faisait dans des conditions épouvantables. On créait à l'époque des maisons qui étaient basées sur des ressources communautaires. Puis on essayait d'aider les gens, d'accompagner les gens dans la mort comme on pouvait. Des gens qui, bien entendu, mouraient sans leur famille, entourés d'amis et de la communauté uniquement. Donc on était dans des conditions extrêmement difficiles. Et je pense qu'aujourd'hui, j'ai une petite pensée aussi pour tous ces activistes SIDA qui sont battus aussi pour... on parle beaucoup autour du cancer et c'est une réalité, mais je pense qu'aussi au niveau de la réflexion autour du SIDA, on a beaucoup réfléchi à ces questions-là. Puis il y a quelques mois, j'ai eu malheureusement l'obligation d'accompagner une de mes très bonnes amies à travers les soins palliatifs à Montréal. Puis là, j'ai vu la différence. J'ai vu alors je pense qu'il faut avoir une vision positive des choses. Je vois déjà l'énorme différence en 25-30 ans, où elle est décédée en soins palliatifs. On a pu l'accompagner, on a pu prendre du temps avec elle. La famille a pu se réunir. Donc c'est sûr que ça reste un processus complexe avec des problématiques relationnelles de toutes sortes et j'ai pu me baigner là-dedans. Mais j'ai vu aussi le progrès. Puis je pense que c'est ça qui est important. Puis à la vue de tout ce qui s'en vient aussi, c'est majeur. Donc les enjeux sont bien entendu sont multiples. D'abord les enjeux de capacité, on a pu les voir et j'appuierai la question d'avoir éventuellement à un moment ou à un autre une stratégie nationale. Je pense que CFHI est capable de donner le ton de ça, mais il va falloir qu'il y ait du support à un autre au niveau gouvernemental, bien entendu. Donc les infrastructures, c'est majeur. La base est là, toute la base est là. Les questions sont posées aussi, ça c'est important, toutes les questions sont posées. Je pense qu'on a fait le tour des défis, on sait ce qu'il faut faire. Maintenant, on doit se donner une cohérence dans comment le faire. C'est ça un peu que j'ai vu aujourd'hui avec beaucoup de créativité. La chose qui m'inquiète le plus en tant que patient, en tant que citoyen, je dirais c'est plus la transformation, comme le disait notre ami Pat Green ce matin, la transformation émotionnelle, c'est-à-dire la capacité, la maturité de notre société à faire face à la mort. Alors comme disait Pat Green, les soins palliatifs, les soins de fin de vie, c'est une célébration de la vie et de la mort, mais on n'est pas vraiment une société qui a l'habitude de célébrer la vie, peut-être célébrer la mort moins. Alors il reste beaucoup de choses. C'est un changement culturel profond qu'il ne faut pas sous-estimer, à la fois pour les patients et les familles qui vivent le processus, mais bien entendu aussi pour les professionnels de la santé. C'est vrai pour les soins palliatifs, c'est encore plus vrai pour l'aide médicale à mourir. Je travaille à l'intérieur d'une faculté de médecine, je vois le poids pour mes collègues médecins et les questionnements que ça leur pose, même s'ils y croient beaucoup. Alors il y a une question là, puis ce que je dirais, c'est que ce qui est important, c'est qu'on reste serein et qu'on évite les débats moraux. Ça a été dit aussi tout à l'heure. Je pense que ça, c'est majeur. On n'est pas dans un débat moral, on est dans un débat ou dans des questions où l'importance principale, c'est que les patients aient le choix de faire ce qu'ils ont envie de faire avec leur mort. Puis qu'on reste vraiment focalisé sur cette question-là. Et c'est aussi pour ça que j'insisterai sur l'importance. C'était le cas, je pense, d'une grande partie des projets qui ont été présentés aujourd'hui, sur l'importance d'impliquer les familles, les communautés, dans tous les projets d'élaboration de dispositifs comme ceux de soins palliatifs ou de soins de fin de vie, pour être sûr que ce soit des projets co-construits et pour être sûr que véritablement on va être capable de s'adapter aussi au contexte spécifique de chacun. Parce que bien entendu, on est dans la spécificité humaine au maximum, on est dans l'adaptation à chaque individu, chaque famille, chaque contexte. Alors bien entendu, c'est un travail collectif, ça ne peut être un travail de professionnel de la santé puis de communauté de l'autre, c'est un travail de partenariat. Moi, je me bats pour le partenariat depuis des années. Mais l'enjeu, la question des soins palliatifs, des soins de fin de vie, c'est la question la plus importante et le défi le plus important en termes de partenariat entre les patients, les familles, les professionnels de la santé et les communautés. Alors si on arrive à relever ce défi-là, bien entendu, c'est l'ensemble des soins qui vont profiter de cela. Et pour finir, je voudrais revenir sur cette question du changement de culture. Vous savez, pour ceux qui connaissent ces approches Lean, généralement, on a tendance j'aime pas trop le parallèle que je vais faire, mais bon, je vais le faire pareil, parce que vous connaissez la plupart, vous connaissez Lean. On dit souvent que Lean, c'est une philosophie d'ensemble. Les soins de fin de vie, ça doit être une philosophie d'ensemble. Un patient, peu importe, ça doit être quelque chose qui doit imprégner l'ensemble du système. Ça doit être quelque chose que tous les professionnels, la population est très peu informée encore. Là, il y a besoin d'un travail multidimensionnel sur cette question-là pour que ça devienne, encore une fois, qu'on soit capable un jour, en tant que société, de célébrer la mort. Voilà. Merci.
Merci bien, Vincent. Our next presenter, Dr. Dores Barwick, Executive Director, BC Centre for Palliative Care, a provincial hub for innovation in the areas of advanced care planning, integrating the palliative approach to care in compassionate communities. She's an associate professor in the Division of Palliative Care, Department of Medicine at UBC, and she's won several awards for some of the groundbreaking work done when she was the medical director for the Fraser Health End of Life program. Been a speaker at multiple international and national conferences. She's a member of Canadian researchers at End of Life Care, CareNet, and a past president of the Canadian Society of Palliative Care Physicians. Dr. Barwick.
So is this on? Yep. So I'm almost not sure what hat I'm wearing when I show up where. So I think what that speaks to, as I think about just what we've seen today, what we've heard today, is the need for a new kind of person. A knowledge broker who can take things from the bedside and work them to the boardroom and then work them out into the community. And I think that's kind of what I was seeing and hearing today, is as we celebrate what each of us brings to the table, then we can begin to develop new kinds of collaboration, new kinds of partnerships, and we can catalyze new conversations. So the BC Centre is very much situated in this space in between. And depending on the audience, I think we need places like that where people can come together to have more thoughtful conversations. And I think what we need to do as well is to be somewhat more intentional at breaking down some of the hierarchies and the silos and that sort of thing, so that we kind of create a space where all of us have a voice and then contribute together in that. So our intention is summarized by sort of three kind of words at a system level, trying to promote a public health approach to person-centered care for all of those living with serious illness. And you could talk about that as more, better, earlier. So the earlier we start to have these conversations, the more that we talk about what's real and we help people understand their options, the better the care, because it's more aligned to their goals and values. It's more aligned to the kinds of services we should be providing in terms of community-based options versus intensive care and others. And more providers that are available and are skilled and trained to deliver this care at every level, so that we're not clustering care in hospitals or in hospices, but that actually that care and that knowledge and skills is dispersed through the whole system, and as we integrate and adapt and embed a palliative approach to care for all healthcare professionals, but also, I think, teaching people to really know how to integrate the community voice. So we've been very intentional in terms of not just partnering with, but actually empowering that voice. And that requires some intentional kind of leveling of the playing field, of empowering people so that there's not just one or two people sitting on at a table of 20 people, but that actually you're asking them what their ideas are and how we can come alongside of them and bring those ideas to fruition. So we have a seed grant program that in some cases gives several $1,000s, but has been transformative at a community level. We're partnering right now with 36 different communities to do various projects that are mostly their own ideas or ideas that we have where we train them in a coordinated, evidence-based kind of provincial approach to advanced care planning workshops delivered by community volunteers. And the transformative change that results in that the volunteers grow. They experience personal growth as they do something that maybe was new for them. The participants grow as they acquire new information, new skills, new attitudes to move forward. And suddenly, there's this catalytic effect. Transformation happens, and things continue beyond the scope of what you initially defined, because now there's passion and energy, and we're all in it together. We're all working together. We're all kind of making something better come out of what for many people is a dark time. And I think that's one of the core messages for palliative care, is we truly believe that something good can come out of difficult circumstances, but that it requires courage, it requires a will to act. And I think that for me was the missing ingredient in the mind, body, spirit, emotion thing. We also require a will. The awareness that what I do as an individual can make a difference. What I do with others makes a bigger difference, and what we can do together is greater than the sum of the parts. And I really think that we need to think about what that looks like, and that needs to be at local levels, within your own faith communities, within every setting that you are with together with others. You can make that change happen. You can make it happen in the care that you provide by acknowledging that this is the patient and the family, and that there's a bigger network of people. We can do it in the way we bring people together at practice level, so we're including evidence-based research and all the disciplines that carry this passion to go forward. And then we can do it at a system level, and we need to introduce more regular measurement, and we need to make people accountable for outcomes at the system level, at a practice level, at a patient family care level. And I think then we can start to kind of get better and better at what we do for everyone and in every way. Thank you.
Thank you, Dr. Barwick. Next, we'll hear from Leisha Babiak, who is Executive Director of Government Affairs for Johnson & Johnson Canada. She chairs the cross-sector J&J Canada Government Affairs Council, and has been with Johnson & Johnson for 17 years. She's been active in many committees and boards, including chair of Biotech Canada Health Advisory Board, and has been member of various industry associations in the life science sector, as well as the Ukrainian Care Center board member and a member of the Alliance Hospice Board. She's previously worked in the Ontario Ministry of Health as Associate Director with the Drug Programs Branch. And these responsibilities, I know, can be extraordinary, great grounding for any career in health administration. So please, we'd like to hear your comments. Ms. Babiak.
Thank you very much for that introduction. And I might have worked for Terry Sullivan at one point as well. I don't know.
It's very possible. We all do. We decided.
And delighted to be here today. Today was truly informing and impactful. And on behalf of myself and Janie Shin, my colleague from Johnson & Johnson, we're delighted that Johnson & Johnson was able to sponsor today's event. As the Deputy Minister mentioned, I come at this conversation as a senior leader within J&J, as a previous board member of Alliance Hospice, as a member and then president of the board for a 194-bed long-term care facility, and also as a former bureaucrat of the Ministry of Health. But also as a daughter who lost her father to diffuse Lewy body disease and made the decision to have him stay in the nursing home rather than go to a hospital when he had pneumonia and see him die in either the ambulance or in the corridor of the hospital. Back to topic. I loved this morning, loved the Dragon's Den of palliative care, which is awesome. Also terrified by this red light of terror, so I'll try to ignore it actually. But I will speak from notes to ensure.
Ignore it at your peril.
Well, maybe I can just cover it up. Perhaps I will speak from my notes just to ensure I can, as efficiently as possible, come across with some thoughts. In the area of health technologies, we've seen significant shifts and transformations in the healthcare system, but also in the industry itself. And perhaps these offer some useful insights as you seek to drive systems-level improvement in the approach and delivery of quality integrated palliative care. Payers made very clear that incremental innovation, or the Me Too's, as we all come to know them, were not valued and would not be paid for. So industry responded. They revamped their R&D approaches and started to drive its innovation efforts towards major areas of unmet need. This has led to major changes in our innovation model. As an example, more partnerships with external innovators and scientists, more of a decentralized approach to R&D in an effort to invigorate traditional in-house R&D efforts. Given the exhaustion of low-hanging fruits, if you will, that is more easily identified innovations, has led to a major effort to rethink and redesign how innovation was undertaken. At Johnson & Johnson, we have prioritized areas of focus on addressing unmet needs with specialized products for small, unique patient populations: hepatitis, oncology, severe rheumatological conditions, and a continued focus on neuroscience and mental health. A plethora of interesting possibilities lie ahead of us. J&J is investing heavily in a number of areas, including the human biome, and in disease interceptors, that is, products that may halt the progression of disease before it emerges, and curing diseases which were previously incurable. With specialization comes increased cost. It has become more difficult and challenging to identify innovations that offer significant advances in therapy. Also more difficult to recoup R&D costs, as these therapies are used for a fewer number of patients versus the blockbusters of the 80s and 90s. As an example of a major leap forward were the recent hepatitis C treatments. These are curative, a major innovative development for patients that faced a lifelong deterioration in their health previously. The challenge became that the healthcare system with silo budgets found it difficult and challenging to pay for these curative therapies. The costs of new therapies are paid for by the drug budget, but the benefits and savings are diffused throughout the healthcare system, which previously carried the burden on managing the various complications associated with hepatitis C management. There was and still is a huge outcry about the burden of paying for these curative treatments by public and also private payers. So a key challenge for our innovations is payer ability to pay for innovations. What happens when we cure the incurable, but the cost is prohibitive for payers who are limited to working within the fixed envelope of drug budgets, and when the benefits are realized elsewhere in the health portfolio? We believe that that there is a need for greater collaboration and dialogue on how to find innovations within the system as a whole to avoid siloed budgets becoming barriers to innovations. There's also been an emerging focus on real-world data to augment knowledge of how effective and safe a therapy is in the real world, not just in controlled randomized pre-registration trials. We are, however, encouraging challenges in securing access to data and also how RWE informs decision-making. While decision makers are open to real-world evidence, they aren't always ready to accept it, and questions arise as to its validity. In this area, what we're undertaking is a collaboration with payers and healthcare systems to co-create research questions to address gaps and enable better policy and decision-making. So hopefully, our anticipation is by working closely with health systems and payers in co-creation will hopefully lead to a better result. I'll just comment briefly that it's not just in pharmaceuticals, but we also find in medical devices as well, this challenge of siloed budgets that limit the ability of take-up of and adoption of innovations due to a difficulty of moving funds from, let's say, the hospital silo budget to the community. So these are some of the challenges we faced. Reflecting on this, what is needed to transform the system? We need innovative ideas entering the system, challenging and disrupting the system. J-Labs and a decentralized R&D system has helped us do that at Johnson & Johnson. We need a system that is responsive and willing to take risks, and we're seeing pockets of positive receptors across Canada, from various health authorities in British Columbia to the Alberta government with some of the partnerships we've struck there, and a number of innovative things that are occurring with the Ontario government. We also need leadership to experiment and innovate and be flexible and empower change in the system. We need the ability to work across ministries and also within ministries and have flexibility to do so. And we need the ability to attract and develop strategic thinkers. But a key challenge is the budget constraints that everybody operates under. When I served as president of the Board of Long-Term Care Facility, first as a member, later as a chair, it was striking how difficult it was for them to think about how to undertake innovative changes and approaches given the extremely tight budgets that they operated on. Their leadership, too, was limited in time and in capability at times. The need to continue to develop leaders within this sector and enhance their strategic, fiscal, and change management capabilities are very important.
Alicia, we'll ask you to summarize, if you don't mind.
I'll just summarize by saying then, patient voice, critically important, recognition of the full value of that innovation brings, and also having different levels of government and different silos within, let's say, a ministry working more collaboratively together.
Thank you. And our final speaker of this session, Dr. Becky Palmer, Chief Nursing Officer for the First Nations Health Authority, British Columbia. She holds a PhD in nursing from UBC, a nurse midwife certification from the University of Alberta. And she comes to the First Nations Health Authority from BC Children's Hospital and Women's Hospital and Health Center, bringing with her 25 years of experience in nursing practice, education, and research. As Chief Nursing Officer, Dr. Palmer has leadership of the FNHA's largest direct care portfolio, nursing services, and oversees both operations and transformation of the nursing program. Dr. Palmer.
Thank you. Am I live? I am. First and foremost, it's an honor to be with you today on National Aboriginal Day. Thank you for the invitation. And want to acknowledge the traditional territories that we're on. Did a little research about the territories, and I thought this was relevant today, and I'll read it so I do it justice. I read that the territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. So in the spirit of that, I thought today for us meeting and sharing and caring about palliative care and our peoples was really relevant and important, so thank you. A little bit about who I am and how I come to this work. So holding many hats like all of us do, as a daughter, as an aunt, as a sister, as a mother, as a spouse. And as you introduced, taking hold of the inaugural CNO position at First Nations Health Authority. I've also had the privilege of holding the hands of those coming into the world and those who are leaving us as well. So today I'm sharing a bit of perspective from First Nations around death and dying, specifically around going home and the celebration, and Pat so eloquently this morning spoke to that, our elder opening the day, around how there's many different perspectives when you look at death and dying. And for First Nations peoples, it's a way of celebrating going home and going back to our grandmothers and our grandfathers. And for survivors, it's around the process of letting go, and how do we do that in a good way. So a little bit about First Nations Health Authority, for those of you who might not be familiar. We're the largest province-wide organization serving the entire province of British Columbia for BC First Nations. In October of 2013, First Nations Health Authority took over from Health Canada's the Inuit and Health Services branch to deliver health care across the province for BC First Nations. The focus of the organization has largely been on advancing the health and wellness philosophy of First Nations in BC, stabilizing and transforming services and operations, and nurturing partnerships with First Nations governments and health system partners. So basically, we have a little slice of federal work, a little slice of provincial work, a slice of regional work, and working at a community level. And we have over 200 bands in the province of British Columbia with the goal of self-determination. So when we talk about transformation and we talk about innovation, I would describe First Nations Health Authority as social innovation towards self-determination. And that is massive for BC First Nations. Absolutely tremendous and pivotal time in our history. So talking a little bit about our work with partnering with First Nations on what a good death is and what it looks like to go home, and the beliefs, the protocols, the ceremonies, and the traditions around that. And how to do that, like I said, to both go home and let go in a good way. We're learning a lot from our elders in that work. and again, Pat alluded to this morning, is how do we look at the whole person? And I heard a lot of that in your innovation today that's person-centered. It's around not just acknowledging the physical aspects, but it's acknowledging the spiritual, it's acknowledging the emotional, all aspects of the human body, so very holistic. What we've learned from our elders, and we had a elders gathering in late last year, and what they shared with us is that they want physical spaces and care providers that are culturally safe, that are flexible in accommodating cultural practices and are practicing cultural humility. I would say the largest bulk of my work is around helping to incorporate trauma-informed practice and incorporate cultural safety and humility in practitioners' work. And those are big concepts, and I would have to tell you that as you unpack them and you see systemic racism and bias in everyday work, which I've been witness to, I grew up in a system that I didn't see that, and I see it now, and I live it. And the opportunity to unpack what cultural safety and humility is in being with people as opposed to doing to and doing for is a tremendous paradigm shift. And I think what we learned in hearing the speakers this morning and also your projects is if we're providing care in a culturally safe way, which we're approaching with humility, that we apply trauma-informed approaches to our everyday ways of thinking, that we're incorporating different ways of knowing, that there's an opportunity here to bring together two different paradigms potentially and others and find the best of all worlds in the provision of care for our peoples. I know my time is near here, so I'll close by saying the biggest thing that I've learned, and I invite you to think about as you move through your own journey of leadership, because leadership is not for the faint of heart, and this is not easy work, is that culture is medicine, culture is healing, and culture is wellness. And if you're thinking of those things as you go forward, it'll help our peoples, all of them, First Nations and others, to move forward in a good way, to go home in a good way, and for those of us that are still here to be able to let go in a good way. I'll close there. Thank you.
Miigwech, Dr. Parmer. So thanks to all speakers for different perspectives on the challenge in front of us, understanding better ways to allow people to come home. That's a very lovely way of expressing it. So the next part of this afternoon's session is a breakout session, and CFHI staff are going to direct you to your breakout. You're going to be charged with